So I'll be talking about the basics of coagulation and coagulation cascade. So this is a coagulation cascade, which I call the textbook version, which you'll all be familiar with the extrinsic pathway and the intrinsic pathway. Where the extrinsic pathway starts with the activation of exposure of tissue factor. So tissue factor activates factor 7, and activated 7 in turn activates 10 to 10A, and the 10A in the presence of 5 converts thrombin to thrombin, and thrombin converts fibrinogen to fibrin. While in the intrinsic pathway, there is activation of the contact pathway with activation of 12 to 12A, 11 to 11A, 9 to 9A, and 9A in the presence of its cofactor 8 activates 10 to 10A. From this point, it is common between the extrinsic and the intrinsic pathway. Now, this pathway was proposed by Robert McFarlane and Oscar Retnoff in the year 1964, a separate publication in the same year. Now, to understand the problems with this cascade, let us go through a case scenario. This was a 44-year-old lady awaiting a coronary artery bypass surgery, referred from Coimbatore due to prolonged apatity, which was repeated on 3 occasions. There was no history of bleeding manifestation. She's had 2 normal vaginal deliveries without any history of increased bleeding tendency. So these are the results. Her apatity is 113 seconds, that is significantly prolonged from the reference range. With a normal PT, her blood counts were normal, her bleeding time was normal. So when you have an isolated prolongation of apatity, it indicates deficiency of either 12, 11, 9, or 8. So when we assayed this patient, we found that the 8 was very high, 283, 9 was also high, 12 was normal, but 11 was less than 1% or undetectable. So how would you explain that this patient has never had any bleeding manifestation in her life? So let's just go back to the coagulation cascade, and let's address the problems with this cascade. We know that hemophilia A and B, which is deficiency of factor 8 and 9 deficiency, have severe bleeding manifestation in spite of having an intact extrinsic pathway. So why are these patients able to form the clot to the extrinsic pathway, where they have normal factors of all components of the extrinsic pathway? Why does factor 12 deficiency patients do not have any bleeding manifestations, and 11 deficiency patients have got variable symptoms? That is, there are some patients who bleed even with a level of 20%, while there are some patients who do not bleed even with undetectable levels, like the patient that we saw. So according to the cascade, the 12 and 11 is required for activation of 9 and 8. Hence, they should bleed even more than hemophilia A and B patients if explained by this cascade. So these were the questions which were not answered by the coagulation cascade. Hegman's factor of the factor 12 deficiency does not cause bleeding. Factor 11 deficiency causes variable symptoms, while hemophilia A and B, which is deficiency of factor 8 and 9, cause severe bleeding symptoms despite having a normal intact extrinsic pathway. Let's try to answer these questions in the upcoming slides. Now, it was discovered that the tissue factor factor 7 complex, now we saw in the extrinsic pathway, there is exposure of tissue factor, and the tissue factor activates 7. So the tissue factor factor 7 complex can activate factor 9 in addition to 12. So it not only activates 10, but it can also activate 9, thereby activating the intrinsic pathway or activating 9 even in the absence of 12 or 11. So 12 and 11 are not required or not essential for the activation of 9. And what happens to the extrinsic pathway? There was a new protein which was discovered, which is called the TFPI, or tissue factor pathway inhibitor, which inhibits further contribution of the extrinsic pathway. So this protein goes and binds to the tissue factor 7 and the 10A complex and inhibits further contribution of the extrinsic pathway. So these concepts were further answered by the cell-based model of coagulation, according to which all coagulation process occurs on the surface of the cell. That is, it can be a surface of an endothelial cell, the platelets, or the monocyte. And this pathway has got 3 steps: the initiation, amplification, and propagation. So the initiation step is what we just saw. So when there is injury, there is exposure of tissue factor. Tissue factor activates 7. The tissue factor factor 7 in turn activates factor 10 in addition to activating 9 also. Now the activated 10 converts prothrombin to thrombin. Now, at this stage in the initiation step, only trace amount, a very minimal amount of thrombin is produced, because further contribution or activation of thrombin is inhibited by the protein TFPI, as we saw previously. Now, what does this trace amount of thrombin do? I would say that I would compare thrombin to like a spark in a matchstick, which is lighting or igniting the fire for further coagulation process. So the next step is the amplification step. The small amount of thrombin which is formed in the initiation step is going to activate 11. It is going to activate the cofactors 5 and 8, and it is going to activate platelets. Now, this is a very important step. As a result, it leads to the formation of 2 important complexes. The 10A's complex, as the name indicates, it causes activation of 10 to 10A, and it is formed by the activated factor 8, the activated factor 9, which is activated in the initiation step, if you remember, and this in turn can convert 10 to 10A. Once 10A is activated, it forms a prothrombinase complex that is formed by the activated 5 activated by thrombin, the 10A, which is activated by the 10A's complex and prothrombin, which leads to conversion of prothrombin to thrombin. This occurs on the surface of an activated platelet. Okay, so this step, or the amplification step, is capable of generating large amounts of thrombin, even without the contribution of factor 11. Now, coming to the third step, which is propagation, this is where the factor 11 comes to play. Now, as I mentioned before, the amplification step is itself sufficient to produce good amount of thrombin. But in certain situations, especially in a post-operative setting, where a sustained propagation of clot of fibrin is required, is where the contribution of 11 becomes important. Now, the 11, which is activated by the thrombin, if you remember in the previous step, is going to activate 9 to 9A, and it is again going to form the 10A's and the prothrombinase complex, like we saw previously. Now, if you see, this is very similar to the intrinsic pathway of coagulation, except for the absence of factor 12. Now, if you see in this full pathway that we saw, we never saw the contribution of 12. It's starting with the factor 11, which is activated by the thrombin from the previous step. So the new pathway has got the initiation, amplification, and propagation, and we saw that there is no role for factor 12 or the Hegman's factor. There's lesser role for factor 11, because if there is sufficient amounts of factor 8 and 9, good or significant amounts or large amounts of thrombin can be generated by the amplification step without the role of factor 11. And here we understand the sheer importance of the factor 8 and 9. Without factor 8 and 9, a proper clot or proper fibrin cannot form. And all this process occurs on the surface of a cell. which helps to localize the clot formation. When we go back to the patient results again, we see that this patient has got very high levels of factor 8 and 9. So in spite of the patient having undetectable levels of 11, she's never bled in her life because sufficient amount of 8 thrombin were able to be generated at the amplification step itself. And this is a very common phenomenon that we see that 11 deficiency patients may not have bleeding symptoms. Now let's try to go through this cartoon to explain the normal physiology of coagulation. So this is a normal intact vessel wall with an intact endothelium, which is covering the collagen and not exposing the tissue factor. You can also see the coagulation factors, the platelets, which is flowing in the blood. When there's an injury, there is breach in the vessel wall, there is exposure of collagen, and there is outflow of blood and its elements to this breach in the vessel wall. So you have to imagine that in the body, the blood is flowing at a very high shear rate or velocity. So these are platelets. Now, when there is a vessel wall, the platelets will also go out of the vessel wall, and you need something to stop the platelets or slow the platelets down to allow it to form a clot at the site of the injury. But because the blood is flowing at a very high shear rate, it may not be possible for the platelets alone to form this clot without some additional help by this protein called von-Willebrand factor. The von-Willebrand factor is an adhesive protein, a large protein, which binds spontaneously to collagen through its collagen and the platelets. Now, this is an exposed collagen. Now, von-Willebrand factor has got binding sites, the A3 domain, which can bind to collagen. It also has an A1 site, which binds to the glycoprotein 1B receptor of platelets. Now, when there is exposure of collagen, the von-Willebrand factor is normally in a coil form. It unrolls itself like a carpet, thereby exposing the binding sites for platelets. So normally in the circulation, because it is in a coil form, the binding sites for platelets are not exposed. So von-Willebrand factor cannot spontaneously bind to platelets. But when there is an injury and the collagen is exposed, the von-Willebrand goes and binds to the collagen through its A3 domain, thereby unveiling or unrolling itself like a carpet and exposing the binding sites for the platelets. Now, when the platelets are coming and they see that von-Willebrand exposed sites are available, it tries to bind to the vessel wall through the von-Willebrand factor. Now, this process is not immediate. So you can see that there is slowing of the platelet, and because von-Willebrand factor is a large multimeric protein offering multiple binding sites, it slows the platelet sufficiently enough to cause platelet activation and finally platelet addition. The process of platelet binding to the vessel wall is called platelet addition. Now, when platelets get activated, there are 4 changes which happen. One is a shape change. Platelets are small disc-shaped structures. They appear pseudopodia, becoming spiculated sphere. This becomes important because it increases the surface area for platelets. If you remember, according to the cell-based model, all coagulation occurs on the surface of the platelets. The more the surface area, more is the area for the coagulation to occur. But the second is a flip-flop mechanism where the anionic or the most procoagulant phospholipids, which is normally seen in the inner surface and not exposed, is now brought to the outer surface of the platelet. That is flip-flop mechanism. The third important step is activation of the 2B3A receptor, which is important for platelet aggregation. So once platelet gets activated, it is rich in alpha and delta granules and also some coagulation factors like factor 5, von-Willebrand factor, fibrinogen. These are all exposed, thereby aiding in more platelet aggregation and activation. Now, if the von-Willebrand factor is not of a large multimeric form, it does not offer sufficient binding sites for the platelets to slow down and finally adhere to the vessel wall. So this is important when you understand the concept of von-Willebrand disease and especially the qualitative defects of von-Willebrand disease. So it is important that the von-Willebrand factor is of the large multimeric form so that it can finally efficiently cause the platelet to adhere to the vessel wall and cause platelet activation. Now, once the 2B3A receptor is activated, it brings 2 platelets together with the help of fibrinogen as a ligand and causes platelet aggregation. Okay, so this is a primary hemostatic plug or the platelet plug. So what are the components here? There is the vessel wall, there is the glycoprotein 1B receptor of platelets, which binds to von-Willebrand factor, and the 2B3 receptor of platelets, which brings about platelet aggregation. Now, the primary platelet plug is the first thing which gets formed when you have a small cut or an injury on your skin, but this is not a strong clot. So if you have a small cut and if you try to fill it with a clot, you see that the clot gets dislodged very easily because this is not a very strong one until it is cemented by the stronger fibrin clot. So let's see what happens next. So the platelet plug is the best platform for clot formation because there's a lot of tissue factor in the near vicinity at the site of injury. And the factors 8, 5, fibrinogen, and 11 are already present within the platelets, which are getting released as the platelets are releasing their granules. The factors which are not present in the platelets are factors 2, 7, 9, 10. These are the vitamin K dependent factors. Now, vitamin K causes gamma carboxylation of the vitamin K dependent factors, increasing the negative charge. Now, once these vitamin K dependent factors have a negative charge, they get attracted to the calcium chloride. Now, once they bind to calcium, they get a net positive charge. Thereby, they get attracted to the anionic phospholipids. Now, where you get anionic phospholipids? We see anionic phospholipids on the surface of activated platelets. So all these coagulation factors get attracted to the anionic phospholipids at the site of the clot formation. So they come and bind to the cell surface. The platelet plug is the best platform for clotting because activated platelet or platelet plug ensure very high localized concentration of calcium, which is essential for the action of the vitamin K dependent factors, and the procoagulant surface is provided by the platelets once they get activated. And hence, this results in the formation of these important complexes that we saw before, the tenase and the prothrombinase complexes, which leads to the formation of the thrombin. So let's see how this happens on the surface of the platelet. This is the surface of the platelet, which has got now activated 5 and 8. Now we saw that thrombin activates the cofactor 5 and 8 in the amplification step. This leads to the formation of the tenase complex formed by the factor 8, factor 9A, and 10. Now, this brings about the 9A and the 10 together and leads to the activation of 10. A small peptide is removed from the 10 and then 10A gets activated. It loses its affinity for factor 8 and gets attracted to the factor 5. And again, now leads to the formation of the prothrombinase complex, leading to activation of prothrombin to form thrombin. Thrombin in turn converts fibrinogen to form fibrin. So now combining both. Now in the body, both these processes happen simultaneously. That is the platelet plug formation, the von-Willebrand interaction, the tissue factor causing initiation of the blood coagulation, the formation of the tenase, the prothrombinase on the surface of the platelets. And this leads to the formation of the stable clot, which is an interaction with the primary platelet plug and the fibrin clot. So when it comes to ordering, now let's go to the next section of the talk about laboratory tests for coagulation. Why and when do you need to order a laboratory test? When a patient has signs or symptoms of a bleeding disorder, or when there's a past history of bleeding or a positive family history, or when the patient is to undergo an invasive procedure such as surgery to ensure normal clotting ability, or maybe to monitor patients on anticoagulation or to monitor liver disease, Whatever be the reason, the aim of the test should be not to miss any step that we mentioned that should put the patient at risk of bleeding. Now, it's not possible to get a detailed investigation in every patient, so we need to do screening tests to try to identify which component of the coagulation process is defective. The screening test is a preliminary or the first step to detect the most characteristic sign of a disorder that may require further investigation. The test should ideally be done in a short time with little effort, should not be expensive, should be sensitive, and that should be the selection procedure for additional, more specific investigation. Now, what are the screening tests for hemostasis? Let's start with platelet count. We know that the platelet is important for the primary platelet plug formation. You have a bleeding time. Now, the bleeding time tests for the primary hemostatic disorder, that is the interaction between the platelet, the glycoprotein 1B receptor of platelet, the von Willebrand factor, and the platelet aggregation. The prothrombin time, which tests for the extrinsic pathway factor, and the APTT or the activated partial thromboplastin time, which tests for the intrinsic pathway factors. But I would say that the most important screening test for hemostasis is history. History occurs when there is a failure of any part of the processes that lead to a stable clot. And it can vary depending upon the degree of the failure and also which phase of the hemostasis is defective. I mean, the pattern of bleeding and the degree of manifestations can be different depending upon the degree of failure and also the phase, whether it's primary or secondary hemostasis. Now, when we look at the sites of bleed, they can be surface bleed. Did some other presentation get shared, or is it still visible?
Hey, sorry, what happened?
I don't know.
Share again. Please.
Is it visible?
No.
Not yet. Yeah.
Yes,
Okay.
visible now.
Thank you.
So when you look at the sites of the bleed, there are surface bleeds. They can be surface mucosal bleeds, that is bleeding from the mucosal flight, like epistaxis, gum bleeding, urinary tract bleeding, GI tract bleeding, or menorrhagia. These are mucosal bleed or surface bleed, or surface skin bleeds like purpura, petechiae, ecchymosis, easy visibility. So these are the type of bleeding manifestation that can be seen in primary hemostatic disorder, like von Willebrand disease, platelet disorders. Okay. Now, a point that I did not mention before with respect to von Willebrand factor is that it also acts as a carrier protein for factor VIII. So in the absence, now normally the factor VIII in the body has a half-life of about 8 to 12 hours. In the absence of von Willebrand factor, this half-life reduces to just 2.5 hours. So when there is severe deficiency of von Willebrand factor, you can also see simultaneous deficiency of factor VIII. Okay. So typical symptom of von Willebrand disease is usually mucosal or a skin bleed. While deep bleeds can be bleeding into the muscle, that is muscle hematomas or pseudotumor formation, or joint bleeding like hemarthrosis causing fixed flexion deformity. It's typically seen in coagulation factor deficiencies like hemophilia A and B. There are other symptoms which can lead to specific clues to the diagnosis, like delayed wound healing. That is, there is a cut, it stops bleeding immediately, but maybe a week later or 2 weeks later, there can be bleeding. That is delayed bleeding or delayed wound healing, umbilical stump bleeding. All these can be seen with fibrinogen deficiency and with factor 13 deficiency. Presence of any of these bleeding symptoms with abnormal extent identifies a bleeder. A mild bleeding disorder usually has infrequent symptoms and usually bleed only with provocation and may not have required any transfusion, but severe bleeding disorders causes spontaneous bleeding without any obvious provocation, requiring more frequent hospital visits and more frequent bleeding manifestations, and the extent and quantity, the frequency is more. Now, this is very important because certain symptoms are quite common, like epistaxis, which can be trivial and may not be significant. So the frequency may be important to understand whether it is a significant bleeding symptom. And there are certain secondary causes of bleed, like gingivitis itself can cause gum bleeding, synovitis causing hemarthrosis, epistaxis related to nose pecking or delayed nasal symptom. So you need to keep these in mind when you're evaluating a patient who complains of a bleeding symptom. Now, to objectify bleeding score and to assess whether the patient is actually having a significant bleeding symptom, there are different bleeding assessment tools available. The ISTH has got a bleeding assessment tool which is now universally used. This is to improve the collection and reproducibility of the bleeding history. Now, there are 14 categories or symptoms, and each symptom is graded from 0 to 4, and a score of 3 or more in children, a score of 4 or more in adult males, and a score of 6 or more in adult female is considered significant. To give an example, each symptom like epistaxis is scored from 0 to 4, the 4 being the highest, which most likely would have led to any blood transfusion or replacement product. And you can see that a score 1 requires quite significant frequency. Like you need to have more than 5 episodes of bleeding per year, or each episode lasting for more than 10 minutes. Only then you can consider the epistaxis significant. So using this bleeding assessment tool is actually objectifying your bleeding symptom and trying to see whether your patient is likely to be a bleeder or not. And also from history, you can also get information about the type of transfusion received, whether the patient has received 8 to 9 or the bleeding manifestation has reduced with the use of blood or FFP or cryo or platelets. All these will be clues to try to identify the type of bleeding disorder. And also inherited or acquired. Now, if you have early onset, possibly inherited. If you have a family history of bleeding, again, possibly inherited. Now, the pattern of inheritance is also important. I'm sure you all know that hemophilia A and B are sex-linked recessive disorders. So the males in the family are affected, like the maternal uncle or the maternal grandfather or maternal cousins. The females remain carriers. Sometimes in females, the values can go low and they can manifest, but generally, it is seen that the history is usually seen in the male line of the family. But autosomal dominant disorders, you can see, it is usually seen with von Willebrand disease, except the most severe type of von Willebrand, which has an autosomal recessive pattern of disorder. Most of the other bleeding disorders, inherited bleeding disorders, like platelet function disorders, Glanzmann thrombocytopenia, or rare bleeding disorders like factor 11 deficiency or 2 deficiency, all these are autosomal recessive pattern, and it is more commonly seen in places where there are consanguineous marriages. So an abnormal coagulation parameter has no major diagnostic role if the patient is non-bleeding. It is just a laboratory phenomenon if you have not correlated that value with the patient's history. So if the patient is not bleeding, has not been a bleeder, or not likely to be a bleeder. So it is very important to correlate your laboratory prolonged apidity with a bleeding history. Now let's try to go through history in some cases to try to understand how much information we can obtain from history. So for the following 2 cases, I would want you to calculate the ISTH BAT score. And to answer these questions, is the patient a bleeder or not a bleeder? Is it a severe or a mild bleeding disorder? Is it a primary or a secondary hemostatic disorder? Is it likely to be inherited or acquired? And if inherited, what are the likely pattern of inheritance, that is dominant, recessive, or X-linked recessive? And finally, what is the likely diagnosis from the history? So I have 2 cases. This is the first case, a 33-year-old female with history of menorrhagia since menarche requiring hormonal replacement. She gives history of occasional gum bleeding. There's also history of epistaxis lasting for more than 10 minutes, for which she took consultation. Her father has a history of gum bleeding and slight prolonged bleeding after trauma, and her paternal grandmother has easy bruisability and hematoma formation. She has 2 children, and the pregnancy and the parturition period were uneventful. So let's try to calculate the BAT score for this patient. So she has menorrhagia since menarche. So that will give a score of 3. So this is the ISCH BAT score, and you can see that if the menorrhagia is present since menarche and more than 1 year duration, then the score is 3. She also has epistaxis, which required consultation. So you can see the epistaxis episode lasted for more than 10 minutes, but it required consultation, so you have to give a higher score. So score is 2. You also had gum bleeding, requiring a score of 1. So overall, her score is 6. Now for adult females, a score of 6 or more is important. So let's try to answer the question, what was the ISCH BAT score? ISCH BAT score was 6. Is he a bleeder or not a bleeder? I cannot see the chat, but I'm just hoping that you're answering the question and maybe you got it right. Is the patient a bleeder or not? Yes, so somebody
Yes, ma'am. Answer is bleeder. Answer is
Yes.
bleeder in the chat.
Yes, very good. So is a bleeder? Is it a mild or a severe bleeding disorder? I can see the chat, so if you can keep on answering. Yeah. Yes,
it looks like there is a severe bleeding.
I can see. Yes, I can. Yeah, so it looks like a severe bleeder. She's had multiple bleeding symptoms since menorrhagia, since menarche, gum bleeding, epistaxis. So it looks like a severe. Sorry. Yeah, it looks like a severe bleeder, I would say. But then if you just look at it, the patient did not have bleeding following delivery. Now I come to that aspect a little later. So what is it likely to be? It is likely a primary hemostatic disorder. Sorry about that. This is because the patient has had most of the symptoms that you see are related to the surface bleed, that is surface mucosal bleed, menorrhagia, surface from an epistaxis and gum bleeding. So all the type of bleeding are mucosal bleed, which is suggestive of a primary hemostatic disorder. Is it inherited or acquired?
Inherited. I'm sorry, sir.
So it is likely to be inherited. Why? Because the patient has had bleeding symptoms since menarche, and also the patient has got a significant bleeding history, family history of bleeding. So yes, it is likely to be inherited. What is the pattern of inheritance? Yes, the pattern of inheritance is likely to be autosomal dominant because you can see a strong history in the father and also in the grandmother. What is the most likely bleeding disorder or possible bleeding disorder in this case? Which is a bleeding disorder which has an autosomal dominant pattern of inheritance? Yes, spondylolisthesis disease. Can anybody tell me why this patient did not have bleeding during her delivery or post her delivery? Possible reason for that? Okay, we'll come to that in the next slide. So let's look at the results for this patient. So the patient had a factor VIII of 31%, had a record for the 1-11 activity of 20%, a normal is above 50, so it is reduced. Antigen is also reduced. So both activity and antigen are reduced, so this looks like a type 1 von Willebrand disease. Now this patient might not have had bleeding during her pregnancy, possibly because of von Willebrand levels along with factor VIII increases during pregnancy. Yes, so that could have possibly protected her during her delivery. So this is a type 1 von Willebrand disease. Now let's look at another patient, an 11-year-old boy. Referred by ENT surgeon with 2 episodes of epistaxis with no local cause. One nosebleed required pressure externally on the nose for 5 minutes, and the other didn't require any intervention since it was noticed on touching the nose. No past or family history of increased bleeding tendency. So let's try to calculate the bleeding score for this patient. He's at epistaxis. So he's had 2 episodes of epistaxis. Okay. But I think he went to, so what would be the score for this patient? So his episodes, if you see, not more than 5 per year, or it does not last more than 10 minutes, but he has consulted an ENT doctor for that, so consultation. So it might be a score of 2 for that. But what is a significant score for a child? A score of 3 or more is significant for a child. So even a score of 2 is not significant for a child. So is this a patient a bleeder or not a bleeder?
Not bleeder.
Yes, not a bleeder. Yes. Is it a mild? If at all it is a bleeding disorder, is it a mild or a severe bleeding disorder? Yes, it is a mild bleeding disorder. Is it likely to be primary or a secondary hemostatic disorder? Primary, because the bleeding is a mucosal type of bleeding. Is it likely to be inherited or acquired? If at all, if it was a bleeding disorder. Inherited? No. Okay, so yeah, so in this case, there's no family history of bleeding, but because this is still a child, we cannot say, but possibly not inherited. But because it is a child, we cannot say whether we cannot definitely say that it is not inherited. But from the history, we know that this is unlikely to be even a bleeding disorder. What is the pattern of inheritance? If at all, it's likely to be because there's no family history, it could be an autosomal recessive disorder, maybe. And if at all, it is just a mild bleeding disorder, like a mild platelet effect or a mild von Willebrand disease. So in extensive evaluation, the patient did not show any hemostatic effect, so it was a no intrinsic hemostatic effect. So this, when you look at the history and you evaluate and objectify the history using the blood score, you can understand which of the patients could have a significant, likely to be a bleeder or not. So just summing up what we have learned in the previous slide, so primary hemostasis. For formation of primary platelet plug, you require the platelets in sufficient quantity, and I would also mention sufficient quality. That means the platelet should be able to function appropriately. It needs a normal glycoprotein 1B receptor, which is important for platelet addition. It needs a normal glycoprotein 2B and 3A receptor, which is important for platelet aggregation. The platelet granules and content should be normal, and the release function of the platelet should be normal. And with respect to von Willebrand factor, which is also involved in the platelet plug formation, should be present in normal quantity and also quality. When I mention quality, the von Willebrand factor should be of the high molecular weight form for it to be functional. It should be able to bind to platelet. The platelet binding function should be normal. It should also be able to bind to factor 8, which is one of the other functions of von Willebrand factor. So when you need to test for the primary hemostatic disorder, the screening test will be platelet count and morphology. Morphology becomes important. The bleeding time, platelet function analyzer of PFA 200, and more specific tests like aggregometry, flow cytometry, electron microscopy, and von Willebrand workup. Now, it is important to look at the platelet counts and the platelet morphology because in platelet function disorders like Bernard-Soulier syndrome, you can see giant platelets with thrombocytopenia. So yes, pay attention to the platelet morphology also. Bleeding time, the time taken by a standardized skin wound to stop bleeding, and the standardized skin wound is 2.5 3mm deep and 1 to 1.5 mm wide by the modified IV method. This can be done even by a lancet tip, which has got similar dimensions. So I'm not going to the procedure now, but prolonged bleeding time can be seen in primary hemostatic disorders like von Willebrand disease, Bernard-Soulier syndrome, Dancer's thrombocythemia, platelet secretion defects, and in thrombocytopenia. Bleeding time is not a test that should be done in a preoperative setting. I understand the limitation. We understand the limitation. You should understand the limitations of bleeding time, but it is also important because it is time-consuming, it is subjective, invasive, difficult to standardize, and it can miss the mild disorders, and so on. I'll just come to that in the next slides. Now, what is other? Hello, can you hear me? Okay. So now going to the other screening test of primary hemostatic disorders is a PFA 100 or 200. It's a standalone instrument where you can do the test with just whole blood, and it's a very easy test to do. It tries to mimic the physiological system. So here you need to add. So this is the instrument, and this is a cartridge. So there are two cartridges available, and this is the inside of the cartridge. So you need to add 800 microliter of blood into this reservoir, and the blood flows through a small capillary tube, and its capillary tube is coated with a membrane. And in one cartridge, the membrane is coated with collagen and epinephrine, and in another cartridge is coated with collagen and ATP. So these are platelet activators, and this also activates one relevant factor, the collagen. So this will lead to the formation of a platelet plug formation. This will lead to the formation of a platelet plug formation. Now, the blood is aspirated with a high shear velocity through the capillary tube by a vacuum. And once it comes in touch with the membrane with the aperture, the platelets get activated, and a platelet plug forms at the membrane, which occludes or stops the blood from flowing. So this is measured as a closure time by the instrument, and a prolonged closure time indicates a defect in a primary hemostatic disorder, that is either a disorder of von Willebrand disease or a platelet function or a platelet quantitative defect. So it has got many advantages over the bleeding time. It requires very small amounts of blood, simple to perform, quick tests, and so on. It is sensitive to, especially to von Willebrand disease, but not so much to platelet function disorders. But the problem is, the most important disadvantage of PFA is that it is really, really expensive, and it is not something that laboratories can have, because each cartridge costs 1,500 rupees. Forget the cost of the instrument also. So it's not something that we can do frequent. Most laboratories in India can do. But when we look at the bleeding time in severe bleeding disorders, it has got very good sensitivity for the severe bleeding disorders: 100% for Glanzmann, 85% for Bernard-Soulier, and 68% or about 60% for von Willebrand disease, and 100% for the type 3, which is the most severe bleeding disorder, which is the most common subtype seen in India. So it is a good test to identify the severe primary hemostatic disorders. Okay, provided it is done as per the reference specification, it can be a good screening test for primary hemostatic disorder. The other test, another simple test, is a clot retraction. So you take blood in a glass tube or a clotted tube and allow the blood to clot. Now, normally when the blood clots, the clot retracts and the serum separates out. This is called. Yes, the most common subtype in India is type 3 von Willebrand. Yeah, I'll just come to that later. So the clot retraction is normal and this is how a normal clot retraction looks, but in Glanzmann's thrombosthenia, you can see that the clot doesn't retract or is absent. So this is specifically seen in Glanzmann's thrombosthenia. It is because the 2b3 receptor is very important for clot retraction. Now, when you need to confirm your diagnosis, you need to do platelet aggregometry, which is done using a platelet-rich plasma, which is obtained by a light spin or a low centrifugation of your saturated blood sample. So here, the principle of LTA is you are comparing the platelet-poor plasma and the platelet-rich plasma. So to the platelet-rich plasma, you're adding a platelet agonist, which activates the platelets, and as the platelets get activated, the platelet starts aggregating or clumping together, and more amount of light it will be allowed to pass. Now, so this is compared to a PPP or platelet poor plasma, which is clear and allows 100% of the light to pass through. But the PRP is turbid and does not allow light to pass through. But as you add the agonist and the platelets start aggregating with each other, more amount of light is allowed to pass through. And this change in transmission of light is plotted in a graph like this. And the different changes as the platelets aggregate is represented in the graph. And depending upon the different pattern of the platelet aggregometry, you can diagnose different platelet function disorders. The most classical pattern is seen in Glanzmann's thrombosthenia, where you see an absent response with all physiological agonists, and you see a normal response only with a ristocetin. I would not call it a normal response. You see an aggregation followed by disaggregation in Glanzmann's thrombosthenia with ristocetin alone, an absent response with the other agonists. While the reverse pattern is seen with Bernard-Soulier syndrome, where you see an aggregation pattern with the other agonists, but an absent response with ristocetin. So this is an example of a Glanzmann's thrombosthenia case. The green represents the patient. So here you can clearly see a cyclical aggregation by disaggregation with ristocetin, while you can see that the control, which is represented in black, is normal. Again, you can also see that there is an absent response with collagen, with ATP, and with epinephrine. Now, this is the pattern that we see with Bernard-Soulier syndrome. So there is an absent response with ristocetin, and you can see a response with ADP, arachidonic acid, and collagen. The response is slightly lower than the control because of the concomitant thrombocytopenia that you can see with Bernard-Soulier syndrome patients. This can be confirmed by flow cytometry. So this is a case of Glanzmann's thrombosthenia. You can see absent expression of CD41, which is a glycoprotein 2b receptor. 42b is the 1b receptor, which is normal in Glanzmann's thrombosthenia. And this is a case of Bernard-Soulier syndrome. You can see that the platelets itself are fewer in numbers and going into the red cell plot because they are much larger than almost as much the size of red cells. You can see that the 41 receptor is normal, but you can see that the 42b, which is the glycoprotein 1b receptor, is absent in this case. Now, when we come to von Willebrand disease, it can be classified based on the quantitative defect and qualitative defect. The quantitative defect, there can be type 1 and type 3. Now, the type 3 is the most severe, which is an autosomal recessive transmitted disease where there's complete absence of von Willebrand factor. While type 1 is reduction, but still not as low, not undetectable, detectable, but reduced levels of von Willebrand factor. Now, qualitative is when there is a discrepancy between the functional assay, the activity, versus antigen. The different subtypes here, type 2A, 2M, 2B, and 2N. 2A is when there is loss of the high molecular weight multimers. Now, we saw how important the high molecular weight multimers are for platelet addition. So when there is a selective loss of high molecular weight, that is when there is a type 2A. So in 2M, the multimer pattern is normal, that you have high molecular weight, intermediate, and low, but the binding of the von Willebrand factor to platelets is defective. So that is a type 2M. Type 2B is when there is increased binding of platelets to von Willebrand factor, and this can paradoxically cause bleeding because once platelets bind to von Willebrand factor, they get cleared from the system almost immediately, resulting in a selective loss of the high molecular weight multimers. So when the patient actually bleeds, the high molecular weight multimers are not there. The type 2N is a factor 8 binding defect. So for screening for von Willebrand disease, again, you can use a bleeding time, the PFA 200, and apatity. It is not a very sensitive test, but because you see factor 8 deficiency in some von Willebrand disease patients, you can have a prolonged apatity in von Willebrand disease, especially the severe forms. More specific tests will be to look at the factor 8 levels and to look at the activity of the functional and the antigenic assays. So in type 2 von Willebrand disease, you see a discrepancy between your functional assay, which is much lower than your antigenic assays. So these are other assays which are available, but I'll not be going through in detail. Now, when you want to look at, we talked about the primary hemostatic disorders. Now, let's go on to the secondary hemostatic disorders. So all these factors are present in the plasma. So you need to do the plasma-based test, and here the pre-analytical role, not just in secondary hemostatic, in all coagulation tests, pre-analytical plays a very important role. So screening tests for extrinsic pathway, we have the prothrombin time. It is the time taken by the saturated plasma to clot in presence of tissue factor and calcium chloride. So the tissue factor, thromboplastin with its bound negatively charged phospholipid. So the tissue factor activates the factor 7 and causes a clot formation. So it will test all components of the extrinsic pathway. The best method to report prothrombin time is along with the INR and the reference range. What is INR? So let's try to see this through an example. The prothrombin ratio is a ratio of the patient's prothrombin time to the control prothrombin time. So let's try to see an example to understand the concept of INR. So there was a patient who was discharged after deep vein thrombosis and he was put on warfarin and he had a prothrombin ratio of 2.5. So normally in patients on anticoagulation, you would want the INR between 2 to 3. So he checks in the laboratory near home and he found that the prothrombin ratio was less than 2, that is 1.6. So the doctor increases the dose slightly, the local doctor there. And 3 days later, he was found to have a prothrombin ratio of 3 and he was unconscious and he was found to have a CMS bleed. But same time when he was checked in CMC, he found that the prothrombin ratio was 9. So what is the reason for this discrepancy in the prothrombin ratio? The prothrombin ratio varies between laboratories depending upon the type and responsiveness of the thromboplastin in the PT reagent. There are a variety of good reagents available. Some are good and some are bad. Now, how do you know whether a reagent is good and whether a reagent is bad? The most sensitive PT reagent picks up the mildest of deficiency and exaggerates the difference between ranges of deficiency. That is, PT is abnormal even if the factor 7 is at 40%, and there's a good significant difference in the prothrombin time between 11% and 17%. So at 11%, you would expect the prothrombin time in seconds to be higher than 17, but this may be evident only with a good prothrombin reagent. While a least sensitive PT reagent misses deficiency and will not show the difference between these ranges of deficiency. That is, PT can be normal even when the factor 7 goes to 21%, and there is no significant difference in prothrombin time when between 11 and 17. So that is a bad reagent. Now, international sensitivity index is a value that is assigned indicating the sensitivity of a PT reagent. Most sensitive reagent have an ISI close to 1. Less sensitive reagent will be more than 1.4. It is advised not to use PT reagent with an ISI above 4 and preferably as close to 1 as possible. What is INR? So international normalized ratio is normalizing the prothrombin time, which is expressed as a ratio incorporating the sensitivity of the reagent used. So it can be calculated by the patient's prothrombin time by the mean normal prothrombin time whole raised to ISI. So this will give you the INR for the patient. So it is a standardized system of reporting patients on oral anticoagulation. Now, when we go back to our case, so the patient was discharged on warfarin, had a prothrombin ratio of 2.5 at CMC. The reagent used had an ISI of 1, so the INR is 2.5. He goes to a local laboratory, the ISI is 2.0, so the INR is actually 1.64 raised to 2, which is 2.5. The dose was increased unnecessarily because the patient was still anticoagulated and it was within the expected therapeutic range. But because the dose was increased, his prothrombin ratio increased to 3 in the local laboratory. And if you calculate with INR, it's actually 9. So that is what was seen at CMC also. So this is an example to show how the prothrombin ratio can vary depending upon the reagent use and how you can have a more standardized way of reporting by using the INR. And when we look at screening tests for intrinsic pathway, you have the apatity or the activated partial thromboplastin time. It is the time taken by the saturated plasma to clot in presence of negatively charged contact activators like silica, kaolin, and lactic acid. These are the activators. So here the activation happens, the factor 12 gets activated by these activators and phospholipid and calcium chloride. So it's called partial thromboplastin because it does not have tissue factor. The tissue factor is removed from the thromboplastin. That's why it's called partial thromboplastin. So it tests for the intrinsic pathway. Okay, so all the components of the intrinsic pathway is tested by apatity. So a prolonged apatity indicates deficiency of factor 12, 11, 9, 8, 10, 5, 2, and 5 So when you have an isolated prolongation of PT, it indicates deficiency of factor 7. Isolated prolongation of APTT indicates deficiency of factor 12, 11, 9, and 8. Prolongation of both PT and APTT indicates deficiency of components of the common pathway 10, 5, 2, or 5 When both PT and APTT are prolonged, a thrombin time can be done. A thrombin time contains thrombin, and this picks up 5 deficiency. So it is the time taken for the plasma to clot when thrombin is added. So when you have a prolonged PT or APT, the next step is to do a mixing study. The mixing study can be done with full normal plasma. You mix equal amounts of the patient plasma with the control plasma and you repeat the test. The rationale for doing a mixing study is if the prolongation in time is due to deficiency of the factor in the test plasma, the normal plasma will provide the deficient factor, thereby correcting a prolonged time. For example, if a patient with hemophilia or has factor 9 less than 1% and you're mixing with control plasma with a factor of 9 is around 100%, the mix should have around 50% of the factor 9. So that should be sufficient to correct a prolonged time. So correction of time indicates deficiency of factor. But if the prolongation is due to an inhibitor, which can be a factor antibody or it can be heparin or lupus anticoagulant, normal plasma will also be inhibited by the inhibitor in the patient plasma and the prolonged time will remain prolonged. So no correction such as inhibitor and correction such as factor inhibitor. The causes for no correction can be heparin, lupus anticoagulant, inhibitors to clotting factors, FDPs or D-dimers. So other than normal control plasma, you can do mixing studies with selective or deficient plasmas like 8 serum or more specifically factor 8 or 9 deficient plasma. So if you have a patient with an abnormal APTT alone, you're thinking of it and a patient with bleeding symptom, you're thinking mostly in terms of a factor 8 or a 9 deficiency. If the patient's APTT corrects with 9 deficient plasma, now 9 deficient plasma has all the other factors normal except 9. But if the APTT is not getting corrected with 8 deficient plasma, that is 8 is not there, this suggests a diagnosis of hemophilia A. That is a factor 8, which is present in the 9 deficient plasma, replenish the patient's deficient factor 8, which was not present in the 8 deficient plasma. By this way, you can identify which is a factor which is likely to be deficient in the patient. Further testing requires classification More specific essays to classify as severe. Severe is less than 1%, moderate is 1 to 5, and mild is between 5 to 40%. Now, a word about the action of factor 13. The factor 13, now fibrinogen is converted to fibrin by thrombin, and factor 13 introduces cross-links in the fibrin mesh and stabilizes the clot. So in the absence of factor 13, the clot is not stable. This can typically cause delayed bleeding, but also an umbilical subbleeding in the neonate. The only screening test which is available is because PTA, avidity, thrombin time, everything becomes normal in factor 13 deficiency, is a urea clot solubility test. Because the clot is weak in a factor 13 deficiency patient, if this clot is put in a weak ionic strength solution like 5 molar urea and kept overnight, if the clot is stable, it will still remain after 24 hours. But if the clot is not stable and if there is factor 13 deficiency, the clot will lies even within 6 hours or 7 hours. So this is a screening test which can be done if the specific assay is not available. Importantly, it can only detect severe deficiencies. Take home message here. The cell-based model of coagulation which we saw is a complex interplay between the vessel wall, the platelets, the warm Willibrand factor, and the coagulation factors. History is a key to understanding and diagnosing patients with bleeding disorders. Without any symptoms, remember, an abnormal coagulation test is no value. And with a good history, you may just need the basic test of hemostasis for diagnosis. The screening test for primary hemostasis, and under history, you have a typical surface skin and mucosal pattern of bleeding. The other screening tests are the platelet count and morphology, the bleeding time, the PFA 100 or 200. The secondary hemostasis history will be a deep bleeds like deep muscle hematomas and hemarthrosis, prothrombin time for the extrinsic pathway, APTT for the intrinsic pathway. When you have it for a long time, the mixing studies with controlled plasma and other selective plasmas will help to detect the specific factor deficiency. Thank you. I would request.
There is a question in the chat box, ma'am. What is restore settings and how the test affected by this?
Urvi, can we do one thing? Can we request Dr. Mukul to comment, and then we can have chat questions?
Yes.
Yeah, Dr.
I would request Dr. Mukul, the chairperson, to add just a few words. I'll stop sharing.
Thank you.
Thank you, ma'am.
Extensive discussion on organisms and giving various exhaustive examples to approach of a bleeding disorder, both lab and clinical, and giving the disorders in detail. So explaining various tests and the nuances. So I just be recapitulating whatever she has said with respect to a clinical patient. So like she said that it's important that
Mukul, can we make it full screen?
so it is full screen on mine.
Sir, once ma'am stop sharing, I think sir's PPT will be shared.
Yeah, I think.
So ma'am, please stop. Yes.
Now you share again.
You can share.
So is it full screen now?
No, sir.
It's okay. Carry on with this. Carry on.
Yeah, sure. So like Dr. Tulsi has elaborated that the most important thing is a good clinical history. So starting with the bleeding assessment, family history, and history of stress in the form of any surgery, any trauma, or for females, pregnancy, menstrual bleeding. All these are stressors which can give which can point towards a significant bleeding disorder. Examination for various sites of bleeding and other clues in or systemic disorder in which bleeding can occur. So be it leukemia, aplastic anemia, or other systemic disorders in which bleeding can occur. And lastly, investigation which have been beautifully highlighted by Dr. Tulsi. So she's already discussed in detail about various types of primary and secondary hemostatic disorder. I just want to say that the family history is more commonly seen in the secondary bleeding disorder. One thing is that most primary hemostatic disorder, the bleeding stops by pressure application. But this usually not a case with the coagulation disorder, in which secondary bleeding can still occur despite initial pressure application. Rest of the differences she has highlighted very nicely. Primary screening test, she mentioned about reading coagulogram, but
Mukul, your slide is not moving.
Okay, sir.
We're stuck on slide number 4 right now. Yeah.
Sir, I was on slide 4 only.
Oh, perfect. Sorry, it's fine. Thank you.
So the primary screening test is screening coagulogram, which she has highlighted, consists of PT, APTT, and importantly platelet count as well. Importantly, for both lab and the clinical person is to do this bleeding assessment tool, which she has highlighted nicely. And ICS batch score is the commonly employed bleeding assessment tool which should be the commonly employed bleeding assessment tool for the person who is ordering for coagulation test, and even the person in the lab who is receiving those requests to analyze which patients require extensive bleeding workup. This will definitely increase your pretest probability of a positive outcome. Like you can see, the score varies from 1 to 4 for different types of bleeding. For epistaxis, cutaneous bleeding, and minor ones, even one score has some increased amount of bleeding. However, for bleeds like hematuria, surgery, postpartum hemorrhage, hemarthrosis, and venous bleeding, it's usually even one score is more severe. And for like venous bleeding, the scoring starts from a score of 3. So most of these patients will require some kind of intervention if they have a severe bleed. Venous bleed is usually considered severe bleed in all cases. This is just a brief overview how we go about for the patient with negative bleeding history. If the patient is undergoing a minor procedure, most of the patient end up with only platelet count. For a major procedure, platelet count, and many times we do advise for APTT. If the bleeding history is equivocal, for a major procedure, a screening coagulogram is advised. And if the bleeding history is definitely positive, for a major or minor procedure, whatever it is, detailed evaluation for the cause is advised before we advise the patient for surgery, unless it's an emergency kind of surgery.
Mukul, once again, I think we are stuck on your slide, which is primary screening test. Can you go to one slide? Yeah, the slide just now. Yeah, we're not seeing the slide. Your slides are not moving.
I just keep like this and not shifting to the primary mode.
No, it's okay.
So this is the back score. Just goes on to highlight that the higher score is more important, but for some sites of bleeding like hematuria, menorrhagia, postpartum hemorrhage, hemarthrosis, or even a score of significant for venous bleed, any kind of venous bleed, subdural or intercerebral, that directly goes to the score of 3 or 4. For the screening coagulogram, I just want to highlight that for the patient with negative bleeding history, they're undergoing a major surgery, platelet, and sometimes we do advise for APTT. For equivocal bleeding history for a major surgery, we advise for complete screening coagulogram. And for the patients who have a strong positive history of bleeding, whether they are undergoing a major or minor surgery, a detailed evaluation for the cause is advisable to prevent any perioperative severe bleeding. Unless it's an emergency surgery, we advise for differing surgery without a complete diagnosis. I think with this, I'd like to end my presentation and over to Dr. Urvi for the thing.
Yes. So there is a question in the chat box. Is there predilection for the factor 11 deficiency bleeding manifestation during the neurosurgical procedure?
That's for me or Dr. Tulsi?
Sir, it's not written, so any one of you can answer.
I know that factor 12 deficiency can be seen in post-surgical phase, but I'm not specific. I'm not sure about neurosurgical scenario whether it's different from the others.
So, with respect to neurosurgical, more intracerebral bleeds have been identified with the factor 13 deficiency per se, and obviously with the severe hemophilia kind of phenotype. Specifically for factor 11, the phenotype is pretty variable. Even for factor 7, the phenotypes are pretty variable with respect to bleeding.
Yes.
I
For
hope that answers.
yes, for Tulsi ma'am, what is ristocetin and how the tests are affected by this?
Yeah, so it's very interesting. Ristocetin was actually introduced as an antibody in the market. So, but later on, when they started using it, it was found that these patients had thrombocytopenia. So the cause for the thrombocytopenia was later found because the ristocetin causes activation of von Willebrand factor, and the von Willebrand factor goes and binds to platelets, like the type 2B kind of a von Willebrand, and they get cleared from the circulation. So it was withdrawn from the market, but this property of ristocetin is now extensively used in the laboratory because normally the von Willebrand factor will not bind to platelets. It will bind to platelets only if it is activated, and ristocetin is used as a reagent to activate von Willebrand factor and causes binding of platelets to von Willebrand factor. So in Bernard-Sallier syndrome, because it is a defect in the glycoprotein 1B receptor, the platelets will not bind to ristocetin. The platelets will not bind to von Willebrand factor even after addition of ristocetin. Okay, and in type 3 von Willebrand disease or in von Willebrand defects also, because there is quantitative defect in von Willebrand, with ristocetin you do not see a response or binding of platelets. So ristocetin was also used to measure the functional activity of von Willebrand factor using ristocetin cofactor assay and so on. Again, based on the same principle, ability of platelets to bind to von Willebrand factor on activation. Hope that's clear.
Ma'am, it is written that what is the difference between AJ and exoplasma?
Okay, so I didn't go into that because of short time, but it is a very useful test when it comes to certain, identifying especially some of the rare bleeding disorders. Now, AIDS serum is a chloroserum which is allowed to kept at room temperature about 48 to 72 hours. Now, in the process, AIDS serum itself does not have fibrinogen and prothrombin, and because it is kept for a long time, the labile factors of 5 and 8 is also lost, but the other factors remain. While in adsorbed plasma, you add a barium sulfate to remove the vitamin K dependent factors, that is 2, 7, 9, and 10, and you add to the plasma and you centrifuge it, and then you take out the supernatant. So that becomes adsorbed plasma. So that is devoid of or deficient in the 2, 7, 9, and 10. Now, when you use this in combination with AIDS serum and adsorbed plasma, basically because the AIDS serum is deficient in 5 and 8, and the adsorbed plasma is deficient in 2, 7, 9, 10, you can use mixing studies to identify whether you're dealing with a factor 8 deficiency, and also with respect to rare or 9 deficiency, or with the common factor pathways like 2, 5, and 10, you can identify using mixing studies. So if you do not want to do all the common factor pathways, you can actually do the mixing studies to identify the defect.
Please explain the test related to von Willebrand disease and its interpretation.
Right. So the von Willebrand disease, so the type 3 is very clear. You do not see any von Willebrand factor at undetectable levels. So when I talk about with any test, when you talk about antigen, so it measures the total amount of the factor, von Willebrand factor present, whether it's functional or non-functional. When you look at an activity assay, you are assessing only the functional portion or functional activity of the assay. So the antigen assay is measuring the total. Now, when you look at type 2A von Willebrand disease, the activity assay, which is a ristocetin cofactor assay, which measures the ability of von Willebrand factor to bind to platelets, will be disproportionately reduced with respect to the antigen in type 2. So, for example, if you have an antigen of like say 40%, and you measure the ristocetin cofactor assay, which is a functional activity, it will be let's say 20%. Okay, so the ratio is the antigen is 40 and the ristocetin cofactor assay is 20. So this ratio becomes 0.5. 20 by 40 is 0.5. Anything less than 0.7 is considered abnormal, or you can call there's a discrepancy between the activity and the antigen. Okay, so this is type 2 von Willebrand disease. But in type 1 von Willebrand disease, for example, you have an antigen sitting at 30 and you have an activity sitting at 28. So there is reduction in the von Willebrand factor, but it is a concordant reduction. There is no discrepancy between the antigen and the activity. So that is type 1. So type 2A and 2B, when it comes to type 2, among the different types, almost all the subtypes will have the ristocetin cofactor assay markedly reduced when compared to the antigen, except the type 2N, for which you need other specialized tests. But between the subtypes, if you need to differentiate, you need to do other tests. So I think that will be a little too difficult to explain like this, but to understand that if there's a discrepancy between the ristocetin cofactor assay and the antigen, that is type 2, undetectable levels is type 3, and type 1 is reduced than normal, but still a very close levels of the activity and the antigen.
Ma'am, already liquid reagent is better for PT and APTT, or lyophilized powder is better for these tests. Which is better?
It doesn't really matter. It is just that when you lyophilize, you have to make sure that you lyophilize it completely. Like it should dissolve completely. So as long as that is ensured, it should be okay. It is just that certain PT reagent can settle down fast. Like especially the rabbit brain thromboplastin might settle down. So if you're doing it in semi-automated analyzer, you need to ensure that there's a stirrer in position, because it can settle down sometimes in between, like after 4 hours or so. So that can cause an artifactual prolongation of a PT. So if you're using like certain like particle-based reagents, you need to ensure that you have a stirrer in position so that a homogeneous mixture is always maintained. Otherwise, you might have to mix it in between the if you do not have a stirrer in position. But between liquid or lyophilized, it does not really matter unless you ensure that your lyophilization process is complete.
What is the better reagent for the PT? Same.
So the PT reagent, I think all the different companies have got all good reagents. Again, you have to look at the ISI. There is a thing that when you look monitoring patients on warfarin, it is said it is better to use like not recombinant thromboplastids, but to use the rabbit brain or the base ones. Again, with an ISI close to 1, because the recombinant ones are said to be very, very sensitive to 7. And when patients on warfarin, you don't really need that sensitivity to 7. You need the sensitivity to 10 and 2, which is the one which causes more stable anticoagulation. So it is said to use the non-synthetic phospholipids, thromboplastins for PT monitoring for INR.
And APTT reagent, how much time we can use to maintain the proper temperature, if we maintain the proper temperature?
So for PT, the guidelines say that you can keep up to 24 hours. It can be done even up to 24 hours because it's mostly assaying a stable factor. So APTT within 4 hours. So PT is the only coagulation assay you can actually do up to 24 hours. All the others you need to do within 4 hours. Otherwise, you need to freeze the sample like -20 or below.
No, ma'am, not for the sample. It is for the reagent. Once you
Okay.
prepare that reagent, how
So
much
that
time?
depends upon the reagent. So most of the time, the product insert usually mentions like how long you can keep. Mostly after. So what you can do to prolong the storage is like you can take only what is required for the particular day and keep at 2 to 8. So if you usually it has got a stability, they mention even I think 1 month. I'm not really sure now, but it depends upon the reagent also. But you can even prolong it even beyond 1 month. But if you ensure that you just take it out from the fridge to transfer the required amount for the day and keep it in the analyzer, and the remaining you keep it back in the fridge. So if you can ensure that the time that the reagent spends out of the fridge is minimal, it can actually be used for a longer duration. But ensure that your quality control, the normal and abnormal control are okay.
What is the updated guideline for the laboratory assessment of bleeding disorder during surgical procedure?
With what respect? With laboratory assessment of bleeding disorder, with respect to what I talking about?
Surgical procedure. During any surgical procedure, what is the updated guideline for the
I think-
laboratory assessment of bleeding disorder? So during
I think-
surgery, that is asked by the Shakil.
So I think Dr. Mukul mentioned that routine screening for PTA in patients without any bleeding symptoms is not recommended. Only if they have like unequivocal or some bleeding symptoms, you need to send the PTA. Is that what you're trying to ask? Or I didn't understand.
I just highlight on this that the choosing wisely kind of campaign from they do not recommend much testing for routine surgical procedure in the absence of bleeding history. So whenever there is a bleeding history, you need to investigate properly. If there is no bleeding history, you can go away with minimal investigation, maybe a platelet count or ABCD at best.
But ma'am, chat question are over.
Ma'am, there is one question. Any book to refer for coagulation studies? What do you say about that?
There are a lot of books, but I would say that most of the information is available online right now. I think there are a lot of articles. I think depending upon the practical hemostasis online platform is a very good. It's very good with respect to coagulation. With books, there is thrombosis and hemostasis. There is I can't remember others right now, but it is like I think it is better to go through articles. You will get an online. There's a lot of information available on. Is what I think.